Hey everybody, Dr. Alec here with Kalkstein Chiropractic. So I'm here with Mike today, and we are talking about some pain that he's having in his inferior scapula, the inferior angle of his scapula. And this is something that Dr. Brady has treated before, but we're just taking a second look at it and kind of following up with some of the treatment he's been doing. So Mike, quickly describe what's been going on with you.
Yeah, so I only really notice the pain when I'm deadlifting, but right as I pick the bar up off of the ground, I notice a little bit of a stabbing pain, like right under the shoulder blade itself, just on the right side.
Okay, so you're down, you're loaded for the lift, you initiate the lift, and it's like in that moment of initiation you feel the pain.
Right as it's breaking the ground, yeah.
Okay, but essentially would you say from like mid-shin up you're not having any issues whatsoever?
None whatsoever.
Is it only the first rep, or is it with every continuous rep as you lift off the ground?
It's pretty frequent, yeah. Like not necessarily from the warm-up set, because the warm-up set just isn't probably heavy enough to really trigger anything, but
okay.
The very, very first working set through, yeah.
Gotcha. Understood. So Mike, let me get you, actually, I'm going to have you take a seat and face that direction, if you could.
I'll just take my glasses off.
So when I hear of something like this, my first question for somebody deadlifting, if they're going to have scapular pain right off the ground, is, are you taking all the slack out of the bar before you pull? And I guess if you've never lifted, that might sound strange, but it's pivotally important that when you get to the bottom of a deadlift, that you take the little bit of slack in the bar that exists, you retract your scapula and almost act as if you're pulling before you initiate motion with your legs. So I'll ask you, Mike, do you pretty darn careful to take slack out of the bar?
Yeah, I did take a little bit of time out of deadlifting, so there might be a little bit of form correction that needs to happen as well, but
okay.
I've always been pretty solid about, shoulders down and back and kind of initiating the pull from the legs. And
okay. And are you straight bar deadlifting, or are you trap bar, hex bar deadlifting?
It's the straight bar, yeah.
Okay. So this is another thing. If you were kind of like a lay person, Mike, and if you didn't have an affinity for straight bar, I might suggest, hey, give like hex bar a try for a couple weeks. Because positionally, your scapula has to roll forward on your thorax if you're going to do the straight bar. Even if you have excellent T-spine mobility and you're fully retracted and brought down, your scapula is still just like a little forward at the beginning of that motion when you go to pull. So if you have like any sort of weakness in your serratus, it's going to be exposed. Like it's kind of the perfect position to expose a serrator weakness.
Gotcha.
Is initiating a deadlift. And when you do a hex bar or a trap bar deadlift, your humerus is already like a little more extended and adducted. Your scapula is already in like a more prime position. I personally would be curious if he experiences the same thing with a trap bar versus a straight bar. I want to see how his scapula behaves. How his scapula behaves relative to his humerus. So I can tell that your right side definitely hikes just a little higher, and a lot of people have an asymmetry in their shoulders, and sometimes it's going to look relevant and sometimes it's not, but in the case of Mike, I kind of want to see. So put your arms out to the side there, and Mike, if you could abduct as high as you can for me.
I even felt it was a little crunchy in there too.
Yeah, man, it was a little crunchy. So I don't know if you can see this, if you can hold that position. This scapula winged up beautifully, nice fluid motion, and the inferior angle of this scapula did not, in fact, want to upwardly rotate as it normally would. Something goes on back here called scapulohumeral rhythm, where after a couple degrees of humeral abduction, you're going to run into the top of your acromion. So to get that full range of motion in abduction, your scapula has to rotate upwards. So if your scapula is not rotating upwards, that kind of tells me that there's something going on in the shoulder girdle from a stability standpoint. Like, for whatever reason, your brain doesn't think that shoulder girdle is potentially as stable as it could be, and that's a potential reason why he's not getting the full range of motion there. So just another thing I want to challenge is if you could come up like this. I'm going to put his arm in the scapular plane, get a thumb behind his scapula. I really just want to... Are you resisting at all in that position? So try not to let me push your arm in.
Dead weight?
So actually, I want you to resist me from letting your scapula fall back so far.
Okay.
So I can manipulate his scap a little bit there, a little mushy. Do you feel that?
Yeah.
I mean, you're not stopping me at all.
Yeah, I don't have much there.
So from a stability standpoint, what I was doing there was using his humerus to drive backwards through his scapula, which if his scapula was nice and stable, probably shouldn't give me a lot of give backwards. There's a ton of give there. I'm trying to build a clinical picture around why. Why would he feel pain on that side when he goes to do a particular motion? Is it something functional? Is it something anatomical? And based off of what I'm seeing with Mike, I've taken a look at Mike before, he moves actually quite quite well. So my clinical suspicion with him is that this is a functional issue, like a motor patterning issue around the way that he's firing and using his scapula on his right side primarily. And some of the stuff you saw him doing with Dr. Brady last time, the wall stars, maybe a little bit of the neutral zone stuff on the ground, that's long term, that's what's going to get him out of this pinch. But for now, I'll show you what the manual therapy side looks like of this. So stand it up for me, Mike. So I know that Mike's going to be deadlifting later today, so he's essentially going to get the full spine treatment just to make sure biomechanically he's in a good position to perform. But it's going to be really important to manipulate his T-spine today because scapular stability is predicated on T-spine mobility, which down the chain predicates glenohumeral mobility. If anyone out there is familiar with Michael Boyle's work around alternating stable mobile joint structures. Okay. But I'm feeling that his TL junction is quite stuck too. So Mike, if you could give me a breath in, partner, and all the way out. Nice. You okay with that?
Oh yeah.
Did it beat you up too bad?
No, you're fine.
Okay. Yeah, and kind of right around where these scapular retractors attach, he's carrying a lot of tension. It's his brain attempting to stabilize the structure. So take a big breath for me. Wow.
Oh.
That was huge, partner.
One. Yeah.
Huge, partner. So now I'm going to come in here and palpate his CT junction, which on this side actually kind of gives me some, but on that side, he's a little bogged down. Oh, so Mike, if you don't mind, look to your left for me. And I'm just going to extend your head. Oh, see ya. Right through there. If you don't mind, I'd like to get you on your side facing me, please.
Sure.
Did you do okay with those?
Oh yeah, those are fine.
Okay. You just tell me if it's too much. Just relax like that.
All good.
Damn, dude, you're kind of built.
Appreciate it.
How long you been lifting?
It's about 12 years.
Okay. Nice, man. Always recreationally?
So started originally for losing weight back in high school because I used to weigh like 250.
Okay.
And yeah, and just stuck with it.
Good for you, man. A lifelong habit.
Right.
Nice, dude. Let me get you on your back.
Alright.
You're at the back.
Yeah. How's that going? Yeah, roll over.
It's okay. Beautiful. So I'm just going to come in and check his first rib on each side too. Look to your left for me. Grab my opposite shoulder. Nice, man. That was a good click there.
Yeah, it was.
Look to your right for me. You're the right.
Don't know why I keep doing that.
Grab my shoulder. It's okay. No, that side actually was pretty nice. So I'm just going to check how his cervical spine is doing too. I would expect a little bit of tightness. One of those muscles his brain is using to stabilize his scapula is his trap, which finds its uppermost anchor point on his occiput. So his head probably wants that.
Ooh, that was a good one.
Nice, dude. So here's the deal. I'm actually going to bring you up and have you swing your feet that way again. And I'm going to manipulate his AC joint on either side, give his shoulder girdle every opportunity to move properly.
So you want me at the same time like to resist you a little bit?
Actually, this time I just want you to go limp. Nice. Nice, dude. That is what the manipulation for the spine and the shoulder girdle looks like if I was talking to a patient. You are a patient, but anyone dealing with this kind of shoulder girdle pain, there's a couple other things that we could do, but from a manipulation standpoint, that's it. And at this point, I would send him right out to do some of the stabilization and motor control pattern exercises that Dr. Brady showed him. And I'd be willing to bet that in a couple weeks of work, you would not have this pain anymore. But we'd reevaluate in 4 to 6 weeks to see what the deal is.
I'd be interested to see if Hex Bar would change it too, just to try it.
I think that might be the next video, Mike. Okay, thanks for watching, everybody.